Hey everyone, my name is Lorraine A.T and I'm an assistant professor at the University of Pennsylvania. I'll be discussing our work entitled The Effects of Sociodemographic Factors on Baseline Patient-Reported Outcome Measures in Patients with Foot and Ankle Conditions. This research was actually conducted during my fellowship year at the Brigham and Women's Hospital in Boston. Prior work from our group had shed light on the fact that there were differences in baseline PROMs, so we wanted to better understand and really quantify the impact that these sociodemographic factors had on the baseline PROMs in our diverse patient population. Our goal was to spark more conscientious use of these PROMs in clinical care, research, and policy. At certain points, we realized that our analyses would only be as robust as the data that we collected. In particular, the way that race and ethnicity are captured in our EMR is quite varied. Race is often used as a proxy for many factors, and we didn't have a good way to further characterize by country of origin, immigrant status, or other factors that may influence one's experience within healthcare. We found that our ethnic disparity was largely, but not completely, explained by differences in education level, language spoken, household income, and Charlson Comorbidity Index. To put it another way, we sequentially eliminated each of the aforementioned factors from our model and found that the disparity was not eliminated. So we really had to consider whether race alone, as a visible social construct, engendered enough implicit or explicit biases that ultimately impacted a person's experience accessing and receiving health care. We are hopeful that practitioners change their practices based on our findings. We really believe that acknowledgement of these factors will be crucial to avoid any furtherance of healthcare disparities, and interventions that might mitigate the financial, educational, and language disparities would be the most appropriate targets for these interventions, and that would ultimately help to reduce the differences in baseline scores that we saw. That would be the best first step to addressing the impact of an individual's lived experience with regard to healthcare. There are questions that remain unanswered by our study. There are additional factors that we didn't measure that are also significant contributors to score variation for racial and ethnic groups. And while we didn't have a clear way of measuring bias, potentially PROMs can be useful to this end, and disaggregating data by race or ethnicity can help with the transparency and accountability by identifying areas for further intervention. So we hope that you'll enjoy our work. Thank you.